Thanks, Dr. Vicky. So good morning, everyone. So I'll be talking about bicondylar tibial plateau fractures. I have no disclosures. The real question for this talk specifically on plateau fractures is when you need to have two approaches. So, very simply, when would you want to have a second approach? Basically, it's going to boil down to when you want it to obtain the reduction or when you need it to maintain the reduction in order to have adequate fixation. Why wouldn't you want to do two approaches? Well, really the main downside of a second approach is going to be wound healing or infection issues. You could make a case for it's faster and easier, although I think that's probably the lower priority. So we'll dive a little bit deeper into these. I think everyone's familiar with Schatzker classification for tibial plateau fractures. Not really much controversy, I think, on the Schatzker 1 to 3 lateral plateau fractures. These are all going to be well addressed with a single lateral approach. The Schatzker 4 medial tibial plateau fractures, technically, if they truly involve just the medial plateau, can be addressed with one approach, but I'll talk about a little bit that that's not always the case. And then you have your Schatzker 5s and 6s, which the gold standard is generally going to be dual approaches, but there are some scenarios where you can consider a single incision with a lateral locking plate. So here's just a case of kind of the where there's no controversy about approach. So this is a 65-year-old woman with a Schatzker 2 fracture. You see a fairly deep depression and split. And again, really not much controversy here. This can all be addressed through a lateral approach, both to obtain the reduction. This is sort of an open the book, elevate the articular surface, close down the book, and then the fracture is reduced, and we're going to proceed with fixation. So again, the fixation, you can buttress the split from the lateral side, you can raft under the articular depression from the lateral side, so there's no need for additional approaches. The main reason I wanted to talk about this case was really just to talk a little bit more about the choices of fixation, non-locking versus locking fixation. So these lateral plateau fractures really don't need locking fixation, even when you have a 65-year-old with osteoporosis. And the reason is that you have a really good biomechanical advantage when you're just rafting like this. So because that medial tibial plateau, the area shaded green, is intact, those screws are anchored into the medial plateau, and the depression is being loaded from the lateral side. So those screws are anchored into really dense medial bone. There's no reason to use a locking plate in this scenario. And there are lots of advantages to non-locking plates. They're cheaper, they're often better contoured, and they allow you to get additional compression across the articular surface, which a locking plate does not. Again, that's supported, because it's supported on the medial side by that intact bone, which is some of the densest bone in the body, essentially functions like a fixed angle implant. Now, what about if the medial plateau is involved? And I think this is where it becomes more controversial about what fixation we should use. So if the medial plateau is involved, now that screw is no longer being anchored, and it's being loaded all the way out on the end of that screw by the incredible amount of force that goes through your medial tibial plateau. And that screw is, if it's non-locking, is very likely to fail in that scenario. So this, to me, is really the indication for using locking plate fixation. So now you get a fixed angle implant. You also often get these so-called kickstand screws. That's the next screw down that is also helping to transfer that load from the medial side onto that lateral locking plate. And that's really when you need to consider locking plate fixation. But the million-dollar question, is that enough? Is that enough to maintain the reduction of the medial tibial plateau, or should you add a medial buttress plate, which has a tremendous biomechanical advantage to be directly buttressing over the apex of that fracture? There's not a lot of great data on this topic. This is kind of one of the most cited, biomechanical studies on this topic. But I think what it says still sort of holds true. So they looked at, as a cadaveric study where they did lateral locking plate versus dual non-locking plates. And what they basically found was that you had more subsidence of the medial plateau with the single lateral locked plate. The question is, how relevant is that? It's less than a millimeter difference. Does this have clinical relevance? And this is a case of mine that was very instructive in my practice, in that this can have some relevance. So this is a 43-year-old opioid user. He was in a scooter crash and had this fracture. So, it's a bicondylar fracture, but it's a relatively simple articular injury, but fairly comminuted metaphyseal injury. You also see he has really severe pre-existing arthritis. So my thought was, well, I really don't want to bugger up a future total knee if he's ever a candidate for that. He's also high risk for infection, so I'm going to try to be minimalist and do this all from the lateral side. So fairly straightforward. I was able to obtain the reduction from the lateral, with just the lateral approach, as you can see, of the joint, and able to achieve the metaphyseal reduction using an external fixator. So once that was aligned, past this locking plate, using a relatively MIPO technique, and felt pretty good about the reduction and fixation that was achieved. And I want to emphasize, if you do this, you want to make sure this is you don't want to use like a 3-5 locking plate. You want to use the large fragment locking plates to really maximize the stability you get in that medial plateau. But despite that, you see that over time, it did heal, but it fades. It fades into varus. And this is what you'll often see, I think, when you try to fix an unstable medial plateau, all from the lateral side. So you'll just get some of that substance, some of that varus. And for this guy who already had symptomatic arthritis, being in that much more varus, he's not very happy. Here's the second case, I think, that really illustrates the challenges with lateral lock plating. So this is another patient that he was riding his Vespa in Italy and crashed, and he got fixed in Rome, and this is what they did. So you can see it's, again, a bicondylar fracture. They fixed it all from the lateral side. And what you can zero in on is there's a posteromedial fracture fragment here. So these are a very common pattern in bicondylars where you get a coronal plane fracture line in this posteromedial fracture. And unfortunately, through their lateral approach, they were not able to either obtain the reduction of that fragment or get really adequate fixation. And you can see that they're just getting the tips of those screws on the CT scan are just getting into the anterior part of that fragment, but it's really not well supported posteriorly. It's not reduced. So this is kind of doomed to fail. Now, if that fracture fragment had involved the whole medial tibial plateau, which you sometimes get, that would have been a different scenario. Maybe you could have gotten adequate fixation, but these coronal fracture planes are not good for lateral locking plates. So this is what was done. So we had to pull those screws back. We had to go in and do what really it ought to have, which is a good posteromedial approach. You clean out the fracture line, you get an anatomic reduction, and then apply a buttress plate over the apex of the fracture. And that's the power of what the dual approach gets you, both obtaining the reduction and being able to maintain it with a good quality buttress plate. And he went on to do well. So I think we've talked, so we're doing this two approaches to obtain the reduction or maintain the reduction with adequate fixation. So that's why really for the majority of these fractures, I think dual approaches are going to be the gold standard. But there are some exceptions. So when could you think about running it all off the lateral side? And I think the things that I think about are these. And it kind of has to meet, for me, all of these criteria to think about it. So the first is it needs to be a large medial plateau fragment. And one of the issues with the Schatzker classification, it doesn't really address the different columns of your plateau that can be involved. And Luo came up with this other classification system based on columns that I think is very useful. And so he divided it into the different columns of the tibial plateau. So a lot of these injuries are these posterior medial column coronal plane injuries. Those are the ones that are really not going to do well with the lateral lock plate by itself for the reasons just like the case that we showed. But there are some that involve both columns together, the anteromedial and the posteromedial column. It's more of a sagittal split rather than a coronal split. I think in that case, you're going to get really pretty good fixation from a lateral locked plate, and your screws are all going to land like on the medial side. So that's the first criteria. The second thing is, to me, you really want a medial metaphysis that can load share. So if all the load, if it's really comminuted and all the load's going to end up on your screws, it's probably going to fade, and there's a high risk it's going to fade into varus, like the case that I showed. So ideally, it's a case that's not too comminuted, and then of course. So these are some examples. So the one on the left is like, sort of a minimally displaced bicondylar, or at least the medial side is minimally displaced. So that's going to load share really well. And I think that's a good case to consider just a lateral lock plate. Whereas the case on the next case is a different fracture that's much more comminuted on the medial side. Trying to run that all off of a lateral plate is tougher. Much more risk of fading into varus. And then the last part is just, again, that the approach is not required for reduction. So again, this case that I'm showing on the left image is much more amenable to that. It's essentially non-displaced. So the reduction is really going to occur on the lateral side. There's not much to do medially. So this is a great case to just run all off a lateral lock plate. We get good fixation on that medial tibial plateau and avoid the morbidity of that second approach. The last one I wanted to talk about was just the one part of the Schatzker classification I haven't addressed is the Schatzker 4. So this is the medial fracture dislocation of the knee. Again, it's described as a medial unicondylar fracture, but the reality is that's often not the case because there's often this sort of skid zone when the knee fracture dislocates. You often get depressions on the lateral side. And so it is it becomes a bicondylar fracture at that point. And if this is very common, it occurs in, something like 70 or 80% of these Schatzker 4s have this. And if it's big, you should probably address it. And often that's easiest to address through a lateral approach with a submeniscal arthrotomy where you can actually assess that reduction more directly. So that's what was done in this case. So you get your reduction on the medial side, just like I've been talking about for the coronal plane fracture, and then that little depression gets elevated from the lateral side and just stabilized with some K-wires in this case. And that's what it looks like at follow-up. So just take-home message, lateral tibial plateau fractures can virtually always be treated with a single approach and a non-locking plate. Bicondylar fractures, the workhorse is going to be two approaches. But you can consider one approach and a lateral locking plate if these criteria are met, that you have a large medial plateau fragment, it's reducible without that additional approach, and it's going to be able to load share and have a stable metaphyseal fracture. And then remember on the Schatzker 4s, medial approach is going to be the workhorse, but you may need to add the lateral to address the lateral sided depressions that are often associated. Thank you.